And the first one is from Scarlett Franks to everyone. And if you want to look at them, they're in the Zoom group chat. I have a patient with chronic vaginal pain. No diagnosed vaginismus, vulvodynia, or pudendal neuralgia. Background of gang rape. She also suffers debilitating paresthesia in arms and legs that no specialist can explain. Do you think the pain and paresthesia could be related?
Yeah, this sounds like one of the forms of sensual sensitization. And commonly, without an examination, I can't say for sure. But the thing about these disorders is that people are very sensitive to touch in ways that do not fit patterns of neurological patterns. And they often come together. They are worse during stress and made better as people become more friendly with it. The problem with these disorders is that they tend to mushroom. So you end up with paresthesia, and then you end up with one thumb that hurts more, and then you end up with something in the shoulder and something in the back, and they move and migrate and get worse over time. And that probably has more to do with what we're asking our pain perceptive system to do, which is to turn itself on and become more aware of ourselves as paining people. This is a hard sell, though, to turn it all back. And as Hugh's case shows, it takes quite a lot of kind and integrative ground for people to consider that this is, in fact, not a pathology per se, but really a way in which the body has gone about trying to work out itself. And once you start to get things like pain or torture or PTSD, you're on the road to something which is disintegrative. And in the process of disintegration, we adapt. We're very good at adapting. And then we don't know that we've adapted. So the education of coming back to recognize this as something that needs to be dealt with by all the things that quieten down the system. And that's why working with someone who understands chronic pain here, getting a diagnosis of chronic pain, sensual sensitization, it's not a disorder, it's not a pathology, not a disorder, but it would help in the process of where would you go from here and what would you do with this, and maybe using a pain program, education, with or without psychological intervention, with you coming in and saying they all fit together in some way, and it's good that you get as much help as you can in many different directions.
Thank you, Tony. The next question that I have is from Kim Locklear to everyone. When someone is experiencing chronic pain, is it common for heart rate, blood pressure to rise, or is that something most present in acute pain?
So obviously it's very aware in acute pain. In chronic pain, when it hits the fear response or the anger response, and remember that the fear response and the anger response right next to the pain response. So when you get pissed off with having pain, up goes your blood pressure. Mm-hmm. Mm-hmm. You know, when you get frightened, sometimes your blood pressure goes down, sometimes you get sweating, you get all these other secondary processes. And we tend to think of fear as though it was only something that we know in terms of our label, but the body can do fear without us noticing we're frightened. And the body can be angry without us because we refuse to see it. We refuse to know that we're angry, but the body can be fuming and having all the same responses of anger and fears. And so then it's a process of saying using words that say, it sounds like your body's frightened, or that you've got an objection in your body about this, which is anger, right? And then you don't have to use those horrible words because they're the wrong thing to have.
That seems to echo a bit with some of the things you were describing in your case. Anything you want to add?
No, not really, actually. Actually, not really. And then I was going to say yes. In No, actually, no. I don't. I'm sorry. I was going to answer the first question, but no, that's fine. Thank you.
All right. Okay, I got another one from Baku Ju. Does that mean that we need to get them to take away their attention from pain? Is it the approach that you are suggesting?
Okay, so I think when Tony was talking about the carpet, that if you say don't pay attention to the carpet, the first thing you're going to look at is the carpet. And it's similar to pain. If you try to say don't look at the pain, the first thing you're going to look at is the pain. So, and that focus and that insistence on the focus can be very hard to break. So it's not about saying to someone to look at something different, but to give a different experience and then get to notice the consequence of that experience or what comes out of that experience. So I don't think we can think another sensation, but we can notice it. But that will only notice once we feel safe enough that we don't have to fix our focus on what it is that is alarming us or which is dangerous.
Yeah, I agree. You can't battle it, and distraction only works temporarily. However, there are other concepts that you can use. You can say, look, your brain's really got itself working very hard on one particular thing and doesn't have time to do anything else. How about we try and get it to do other things? That's not distraction. In fact, that is lateralization into the cortex. That's moving away from the amygdala, moving away from the projections into the frontal lobe and moving out into the cortex as a whole. And that's a healthy and good thing to do. And it's not about putting one against the other and distracting versus getting stuck in. It's about your brain has other things to do. How about we talk about how you do that? And in fact, that's one of the things that happens in mindfulness.
Mm-hmm. Thank you. This one, which I think just came after your presentation, Tony. Could this type of therapy be useful in conversion disorder?
It is. It is definitely used in conversion disorder. There's a whole new movement now, especially in the neurological conversion disorders. We used to look at conversion disorders as simply a trauma that happened to you that now is expressed somatically. But what we do know that if you do that for long enough, your soma learns to do it that way, and it becomes a fallback mechanism of your soma. And it will erupt as it erupts, given whatever the circumstances are. So then it becomes something for the patient to learn about as how their body works, and to be able to tell the difference between the epileptic seizure they have and the pseudo seizure they have, and the different markings of that. And people who know they have pseudo seizures and don't feel like they have a say over it, learn to lay down and have their seizures, get up and go, okay, I did that, that's fine, let's get on. Not that flippantly, but basically with that. And there's a whole new school now within the neurological world about looking at this and teaching this. And what is missing is the integration of medicine. The integration, psychological integration of all of this together in the patient. We are forcing people to look at that in medical training now. We're forcing people to look at that in their training as neurologists. You guys have already got a lot of that, but you do need the words that are appropriate to the conversion response itself. They still need to feel like you're taking care of their body.
Mm-hmm. So true. Thank you, Tony. This one I think is more to you, Hugh. Is the overwhelming amount of work and patience required from the patient herself act as an added stressor that contributes to the pain, leaving her stuck in a loop?
So can you read that again, please?
Yep. Is the overwhelming amount of work and patience required from the patient herself act as an added stressor that contributes to the pain, leaving her stuck in a loop?
It's a really interesting question, actually. And, you know, as I said with this client, Samia, there was like nothing seemed to happen for 10 weeks and she kept coming. Like in that 9 months, in that 27 sessions, she missed one session because she had to take her husband to a cardiology appointment. So she was really committed to this. So even though there was something seemingly not happening, something was happening because she kept coming. And I noticed that with a lot of my clients, actually, that they're getting something, and they're getting something enough that it doesn't feel, it's not overwhelming, and that it's not overwhelming. And I guess I'm careful in how I work, that I'm trying not to overwhelm them, because, you know, when people get overwhelmed, they contract, they protect, and it's hard, you know, if people are overwhelmed, it's hard to integrate the work that we're doing. So I try to keep on the right side of overwhelm, I guess.
So, Jorge, do you mind if I add a little
Yes,
bit?
no, please. I was going to ask you. So please, Tony.
I jump on this one pretty heavily because, you know, most people think it's the quality of the therapist, the quality of the space, the therapy, and the technicalities of what we do. They're so important, and they are important. There's no doubt. But unless the patient maintains interest, unless the patient is actually interested in themselves more than their disorder, if you like, or more than their drama, nothing will proceed, no matter how well or how good the therapist is. It simply won't happen. It's good to know your stuff. It's great to know your stuff. But there are some people that just simply are not ready yet, cannot, will not. And we take that very lightly and very gently. A percentage of those over time educate themselves slowly and come back, and then a whole people don't.
Thank you. We'll go to the next question, which is, I have a client who feels comfortable with tension in her shoulder and can't, or I imagine it's uncomfortable with tension in her shoulder and can't let go. She feels losing her body if she relaxes her shoulders. The same with the tension in her jaw.
What's the question?
I imagine the question is, do you have any comments on, you know, what would be the way to proceed?
I think you and I both would say, if it works for her, fine. But why is she seeing you then? You know. Yeah. So, you know, it's really about being able to say, you know, that tension in your jaw is your fear, and your fear is limiting you, and you're being a control freak, and your life is shit. You know, in whichever way you want to say that, maybe not that directly, but being able to say very clearly that, you know, you are limiting your life, and you're here because of the limits in your life, and it's being shown in these tensions you're holding. And the great thing about having them that you can access in terms of shoulders and stuff like that is we've got Hugh. We've got someone like Hugh who will take it slowly, who will gently work with it, who will give you the space and time to explore what's it like to let go and drop. This is not an all or nothing rule. We're not requiring that, you know. So that discussion is really worthwhile doing, especially since most people are thinking about, I either have tension or I don't. And that's not how life works, not how my body works. And it's certainly not how most bodies works. I'm tense by the end of the day, mostly. And I might wake up tense. It comes, it goes, it moves, it changes. And for someone who's afraid of letting go, then it's an all or nothing rule. And we're just talking about increments. And Hugh's the increment guy. That's what he talked about. The increments, the time, the patience, the letting go, all of that. It's beautiful work, and really something that you can so easily let the patient know about, because patients in these sort of ways are so extreme in the way they view their bodies.
Thank you. We've got a few more questions and only a few minutes left. So I'll go to the next one. I have heard that pain is caused by trapped trauma that has not completed its cycle. For example, a child that is trapped in a violent home and cannot complete the natural flight response. Will resolution of the trauma eliminate pain?
I'll let you take that, Sam.
Yeah.
Tony, you happy?
Well, yeah, the answer is probably no. Mm-hmm. One of the things we've learned with a lot of stuff, PTSD and anxiety and all of this, is that which causes it is not that which continues it. So if you mean elimination of trauma, that is retraining the body to be the body it is appropriate to the age it is. That's not about trauma. That's about change, right? And catching up. Mm-hmm. If you mean getting rid of the issue of the trauma and finishing that, then these things are self-replicative. They recreate themselves over and over again. So unless you replace the pattern that the body is doing now, purposefully and with patients working with you, the body will not automatically change.
Thank you. No, it's so true. Not just about chronic pain, but certainly about a lot of the things that we deal with in trauma.
Yeah, sure.
Another question, could fibromyalgia be as a result of trauma? And if so, would it still be called fibromyalgia?
Yeah, fibromyalgia is an interesting thing. We argue, well, firstly, it's in the bailiwick of chronic pain. So, it's a generalized chronic pain. And that being the case, it could be the result of anything. But that, again, what it's the result of is not as important as what do you do about it. Because those results, this is not a linear pattern. By the time you are in chronic pain, you no longer have the pin in the finger going all the way up to the head. What you have is a soup, a very big soup. And you can't solve the soup but by changing the size of the bowl. You can't do that. You've got to then get into all the ingredients, mix and match and work with it all. That being the case, you may know what the cause is. It may be helpful for the patient to know what the cause is, but that still the same work has to proceed. You still end up having to do the same work.
Thank you. Hugh, anything you want to add to this or the previous question?
No, that's fine. Thanks, Roy. That's
okay. I think we're on 8 p.m. now. Let me thank you all very, very much, and particular two speakers tonight. I think it's been wonderful. It's been I think an incredible couple of presentations and a really interesting discussions, and really interesting questions. Now, we haven't done this before, so I'm going to mute you all. Let's give them a big clap and let's see how it works and whether we all don't all go there.